Hello and welcome to Treating Tobacco Use and Dependence, Current Practice Guidelines, a special presentation of the Home Health Quality Improvement National Campaign in honor of 2019's American Heart Month. To start things off today, it's my great pleasure to introduce Cynthia Pammon. She is the subject matter expert for HHQI with the Center for Clinical Standards and Quality, Quality Improvement and Innovation Group in the Division of ESRD, Population and Community Health for the Centers for Medicare and Medicaid Services. Cynthia?
Thanks, Shane. And from all of us at CMS, we want to welcome you and thank you for attending the webinar today. We especially want to thank Dr. Hudman and team for giving us her time and attention today to discuss behavioral and pharmacotherapy interventions for tobacco cessation. This topic is very timely and relevant to National Heart Month. It is also relevant to the national work currently going on now within our own QUITLINE program. I look forward to listening and learning right along with you all. So take it away, Shane and team.
Thank you, Cynthia. We appreciate you being with us today. Note that for today's presentation, 1.25 hours of nursing continuing education credits are available in HHQI University following the webinar when you first watch the 60-minute webinar, either live or recorded, and complete the evaluation and reflective question second. This is approved by the Alabama State Nurses Association. ASNA is an accredited approver of nursing continuing education through the American Nurses Credentialing Center's Commission on Accreditation, or ANCC. These credits are accepted in all states. By the end of today's session, in addition to our guest presenters' content, we hope that you'll be able to explain the effects of tobacco use on a person's health, list 3 evidence-based behavioral approaches for treating tobacco use and dependence, and describe the relative efficacy of FDA-approved medications for smoking cessation. Our experts today are Dr. Karen Hudman. She's a professor of public health pharmacy at the Purdue University College of Pharmacy and clinical professor at the University of California, San Francisco School of Pharmacy. She's a licensed pharmacist and a cancer prevention researcher. She has nearly 30 years of tobacco research experience and has personally provided tobacco cessation training to more than 20,000 health professionals, including students and licensed clinicians. Dr. Hudman's career goals are directed toward expanding the preventive medicine component of healthcare delivery and utilization, along with broadening the clinician's role as an advocate for positive health outcomes through disease prevention as well as treatment. The approaches that she applies in attaining these goals are transdisciplinary, collaborative, and participatory. She was one of the original authors of the Prescription for Change, clinician-assisted tobacco cessation training program, which has been in existence since 1999 and is used globally to train students and licensed clinicians to apply evidence-based approaches for helping patients quit. Currently, Karen's research is funded by the NIH and the Indiana State Department of Health. Our second presenter today is Dr. Nirvana El Khadri, a third-year PhD student in the Department of Pharmacy Practice at the Purdue University College of Pharmacy. She earned her doctorate in pharmacy at Purdue and has 8 years of pharmacy practice experience. For the past 3 years, she has focused her research efforts on at the interface of pharmacy, public health, and addictions. Her academic career goal is to advance patient care practices related to treatment for tobacco use and dependence by preparing health professional students and licensed clinicians to address the tobacco epidemic and become advocates for tobacco prevention and improved health outcomes. At this point, it's my great pleasure to turn over today's presentation to our experts. Thank you for joining us.
Thank you, and thank you so much for the opportunity to talk about treating tobacco use and dependence. This is Nirvana El-Khadragi. Today we're going to talk about, again, tobacco use and dependence. In recent years, we've had some interesting new data that's come to light to give us some better guidance regarding how we should go about treating this health condition. I am not able to advance this slide. Oh, here you go. All right, so Dr. Hudman and I have no conflict of interest. Neither of us have taken funding from pharmaceutical industry or elsewhere. So we can talk honestly and openly about the data and the medications without bias. Everything that we are presenting today comes from the RX for Change program, which was developed in 1999 at the University of California. This website is a useful resource for obtaining all sorts of teaching tools and training tools related to tobacco cessation. And the web address is on here on this slide. Also, at the end of today's presentation, we're going to provide you with another website where you can go and find more resources for training. We'd like to start with what we believe is a profound statement from one of our former Surgeon General, C. Everett Koop. Cigarette smoking is the chief single avoidable cause of death in our society and the most important public health issue of our time. And actually, this was stated in 1982, more than 30 years ago, and it's actually still true today. And as we think about tobacco dependence, there's actually two parts to smoking, and so therefore there's two parts to quitting. We have this physiological addiction to nicotine, which is best treated with medications to help patients be more comfortable while they're quitting, but there's also a behavioral side. So treatment should address both the physiological and the behavioral aspect of dependence. So first we're going to focus on the physiological aspect. I'm sure most of you know what the nicotine withdrawal syndrome looks like. You know, patients feel irritable, they feel angry and anxious, also maybe depressed, and they may also gain weight. Most of these symptoms manifest within 1 to 2 days. They peak within the first week, but they subside within 2 to 4 weeks. So someone who makes it through 4 weeks, then they're basically through the physiological addiction, and the rest is just mostly behavioral side and coping strategies. Nicotine is highly addictive, so I just wanted to show you this graph. Nicotine reaches the brain within 10 to 20 seconds after inhalation, and that's actually faster than D-glucose, which is the primary energy source for the brain. So what really contributes to the physiological addiction to nicotine is that immediate relief of withdrawal symptoms. I'd also like to show you the timeline of nicotine withdrawal symptoms with respect to treatment. So when we think about the addictive nature of nicotine, we want to make sure that our patient is, while they're going through the nicotine withdrawal, that they have medications on board so that they are more comfortable. And so if we think about it, most of those symptoms happen within the first 4 weeks, but then we have these additional 12 weeks to make sure that all the symptoms have gone away. Symptoms that persist a bit longer are increased appetite, weight gain, and cravings. I'd also like to highlight the 2 parts of smoking and therefore 2 parts of quitting. So the medications we take generally for 12 weeks, and that gets people through the first 4 weeks, but then the additional 8 weeks to make sure that pretty much everything is gone. But then the cognitive and the behavioral coping strategies, which is the behavioral side, we need to address those two and make sure that patients have the skill sets that will last for lifetime. I'd like to talk about the medications that are generally used for 12 weeks. We know that patients who use medications are much more likely to be successful. The options that we currently have in the United States are listed on this slide. Over-the-counter, non-prescription options are on the left, the gum, the lozenge, and the patch. And then the prescription-only products are the inhaler, the nasal spray, BUPROPION, sustained release, and VARENICLINE, which is also known as Chainpix. We have generics for the gum, the lozenge, the patch, and BUPROPION, but not for others currently. And these 7 medications are the only FDA-approved medications for smoking cessation. Now let's walk through the different medications and talk about why one would be a better option than another. The gum and the lozenge are available in 2 dosage forms, the 2 milligrams and the 4 milligrams. And the dose selection depends on the level of nicotine dependence. So if the tobacco user smokes the first cigarette within 30 minutes of waking up, then they should use the higher milligram, which is the 4 milligram gum or lozenge. The nicotine and the gum and the lozenge and also the inhaler are all absorbed through the cheek membrane. But what's important to know, and what's important is an important counseling point to patients, is that these medications need to be taken on schedule and not as needed, because they are designed to prevent withdrawal before it happens and not treat it after it happens. Because if they just take it after they start having withdrawal symptoms, then it's not going to work as fast. There is a specific method for chewing this gum. It's not like a regular gum, so make sure the patients read the package insert. Some of the pros for the gum and the lozenge, they might delay weight gain, and that's generally with the 4 milligram, and that's possible because you're not supposed to eat or drink anything except water for 15 minutes before or while you are using the gum or the lozenge. And if you use it every 1 or 2 hours, that's a lot of time during the day when you're not eating anything. And so that's how it might delay weight gain. The problem is adherence is a major problem for using this medication by itself. But if they use it in combination, then adherence is not a problem. Combination is usually done with a nicotine patch. So now I'll talk about the nicotine patch. It's been on the market for a long time. It's one of the most commonly used cessation medications. And the beauty of this one is that it's only once a day dosing. And really the only downside is that there's some patients might not be able to use it if they have skin sensitivities or other dermatologic conditions. But really it's one of the good options that smokers have to consider and it's also relatively inexpensive compared to other options. The nicotine inhaler, the one good thing about it is that it mimics this hand-to-mouth ritual of smoking, but it can be a good thing and it can also be a bad thing because, remember, we're trying to address the behavior, and this is part of the behavior, bringing your hands to your mouth, and, so that's something, that's a behavior you're trying to get rid of. But if a patient comes to you and says, I really have a hard time and I don't know what to do with my hands, that maybe that's a good option for them. A group of patients that I think this might be a good option for them are those who spend a lot of time in the car and they were really used to smoking in the car. For example, people in the transportation industry, like truck drivers, this might be a good option for them. The other thing to remind patients about is that the delivery of the nicotine, it's delivered as a vapor, so temperatures can affect the delivery. If it's too cold, then it won't be delivered effectively. If it's too warm, then it will evaporate. And next is the nasal spray. This is another short-acting nicotine replacement therapy. Remember, all short-acting nicotine replacement therapies need to be dosed every 1 to 2 hours. So they all have this problem of poor adherence. With the nicotine spray, the nicotine is an irritant. So for people who have any type of chronic rhinitis, allergies, or severe airway diseases, probably not the best option for them. It's not contraindicated, but it's not the best choice. I just wanted to show you this graph because we have all these nicotine replacement product options. In this graph, the blue and the green lines, the top ones, are tobacco products, the cigarette and the moist snuff, which is smokeless tobacco. And these are ones that deliver nicotine to your brain very quickly, and it delivers very high levels of nicotine. Now, the ones towards the bottom, those other lines are the nicotine replacement therapy options that we have. And so, as you see, the one that had the most rapid onset is the yellow one, which is the nasal spray. So this is something to keep in mind when you recommend nicotine replacement therapy to patients, is that they're not going to deliver that high of nicotine and that fast. So just make sure that patients are aware that, their withdrawal symptoms are not going to be taken care of quickly. And that's why the short-acting nicotine replacement therapies are taken on schedule and not as needed, because if they wait until symptoms occur, then these medications will not work. And this is a way to streamline selection, product selection, because we have a lot of options, and we also have the combination therapy option, which I will talk about next. So make sure to ask patients if they prefer a prescription or a non-prescription, because if they have a primary provider, then their doctor can write a prescription option, but if they don't have one, then they will have to go with a non-prescription. Another question you want to ask to your patients is if it would be a challenge to take a medication frequently throughout the day, for example, 9 times a day initially, and that's how the short-acting nicotine replacement therapies are dosed. So if the patient says, well, no, that's a challenge, I cannot do that, 9 times a day is too much, I have a lot on my plate, then you don't want to go with the short-acting on its own, but you can combine it with something else. So just asking these 2 questions help you streamline and navigate what options are there. More recent data suggests that combination therapy should be the norm and not the aberration, and people who use it are more successful than people who use a single agent alone. And the way to go about this is by adding the long-term formulation, which is the nicotine patch, and that gives you kind of a steady baseline of nicotine throughout the day. And then on top of that, the patient can take a short-acting formulation, such as the gum, the inhaler, the lozenge, or the nasal spray. And they would take those short-acting NRTs as needed and kind of titrate them in situations where they feel they need more. And on this next slide, we have the dosing of these medications. So for the nicotine gum and the lozenge, you choose the strength based on how soon the patient has the first cigarette after they wake up. And they would use 1 piece every 1 to 2 hours as needed. You want to make sure the patient starts with at least 4 to 5 a day. And then they can also time it according to when they think they need it. So, for example, if they think they really need it in the car when driving to work, then they can schedule to have a piece of gum during their trip. And then the inhaler and the nasal spray are prescription options. They're less commonly used, but the dosing is provided here on the slide. So let's take a look at the data that are pooling studies that are similar. So what we know that when you use a single agent like the gum or the patch on their own, you are approximately doubling the patient's ability to quit in 6 months. If you use the combination NRT, you almost triple it. So what we know now based on this information is that combination NRT, it should be the norm. It should be a first-line recommendation of treatment, not starting with 1 medication and then moving to 2, but actually starting with 2 medications. And those are just nicotine replacement products, which by definition means that they have nicotine in them. Now we have 2 other medications. We have BUPROPION SR, also known as Zyban, and this is less commonly used compared to other products just because it has some side effects and it has some, screening that is required before prescribing it, particularly related to seizure risk. And so it's the only medication on the list of 7 FDA-approved medications that has a true contraindication to use. And in addition, patients should also be monitored for potential neuropsychiatric symptoms related to a black box warning, which Karen will talk about later. The benefit of bupropion is that it is simple, it's used only twice a day, and it also might be beneficial for patients who have depression. But if somebody already is on bupropion for depression and they're still smoking, you do not want to change the dose. You probably want to go with NRT. And the reason I mention this is that if a patient presents to you and you find out that, you know, they have untreated depression, they're still smoking, they're interested in quitting, then bupropion might be a good option because, you know, you're, you know, 2 birds with 1 stone. Otherwise, if they're already on bupropion, then I would not mess with it. I would put them on something else. The other nice thing about bupropion is that it's extremely cost effective, like it's really cheaper than other medication options. So it for the cost, it's a very big advantage. And then the last option, which is the one most recently on the market, but it's been more than a decade now, is the VARENICLINE. You'll remember this medication as one that had a lot of lay press about side effects related to suicide, etc. And Karen will talk about this later, about the safety of this medication. The benefit of this medication is that it's used twice a day, and it has a totally different mechanism of action than the other medications. And also we know that it is the most effective agent, and it's even more effective than combination therapy. So keep that in mind when you navigate the options for a smoker who's considering to quit. The downside is nausea, but if people take it after a meal with a full glass of water, then the nausea is less likely to occur, and it tends to go away over time. And also the dosing, it starts with a low dose and it titrates up, so that kind of helps with the nausea. It may also cause insomnia and sleep disturbances. It also had a previous black box warning, but we still, even though the black box warning is removed, we still need to monitor patients. Another pretty significant downside is the cost of treatment. It's by far the most expensive of all cessation agents. So it costs around $15 a day, which is much more than smoking for most people, unless they smoke 3 packs a day. So now I'm going to turn it over to Karen. She's going to talk about the study that was published in 2016 about the safety and efficacy of these medications. Thank you.
Thanks, Nirvana. Great job. There's nobody better to cover the medications than a pharmacist, right? So what I'd like to do now is transition a little bit to the safety and the efficacy of these medications for cessation. And so in 2016, a paper was published in The Lancet. It was called the EAGLE study. And what the EAGLE study did for us was it compared the different medications. I think I can control it now. Let's make sure. Yep. This is what you'll see. This is the actual article, a screenshot of it, and this was the EAGLE study. And what this was a randomized trial, 24 weeks, and it was mandated by the FDA for the makers of Chantix, which is Pfizer, and the makers of Zyban, which is GlaxoSmithKline. And they were mandated to conduct this clinical trial. It had over 8,000 participants, 140 centers, multinational. And these patients were randomized to receive varenicline with standard dosing for 12 weeks, bupropion SR, which is Zyban, standard dosing for 12 weeks, the nicotine patch starting with 21 milligrams a day with their standard taper over 12 weeks, and a placebo for 12 weeks. And the placebo group was genius, and I'll tell you why in a minute. So all of these arms had very strong interventions for behavioral, which is 13 counseling visits and 11 telephone calls. They were followed for 24 weeks, and their primary outcome was a very strong one in that it was continuous abstinence. So what I'm going to show you now are the efficacy data for these 4 different treatments. And remember, these were randomized. But what they did was they stratified the population by patients. Half of them had a psychiatric diagnosis, and half of them did not. And if you recall the black box warning and all the lay press that Nirvana referred to, it was all about neuropsychiatric symptoms. And so they wanted to make sure that patients who had psychiatric illness were included in this trial because, to be honest, patients with psychiatric illness need these medications to help them quit, probably more so than others. So looking over the 24-week study, what we saw was that varenicline in both groups, looking at them separately, varenicline was more effective than bupropion SR, it was more effective than the nicotine patch, and it was more effective than placebo. Now, bupropion SR and the nicotine patch were not statistically different, but they were better than the placebo. So if you just look at the efficacy data from this study, which is really the first head-to-head trial of these medications all at the same time, varenicline was the clear winner. And you see that not just in the psychiatric cohort, but also in the non-psychiatric. So both groups, it was the most effective. But what this study was really designed for was to try to examine the safety data. And again, looking at the very same groups here, psychiatric and non-psychiatric, varenicline, bupropion SR, nicotine patch, and placebo, what we're showing here is the incidence, which are new cases, of moderate or severe neuropsychiatric adverse events. And what we found was that there was no difference between groups, in either group, non-psychiatric or psychiatric, no difference between the medications. And in fact, if you look at varenicline, if you just look at the numbers, 1.3 versus 2.2 for bupropion, 2.5 for patch, and 2.4 for placebo. So, some people would conclude based on this that this suggests that these neuropsychiatric effects might in fact be a side effect of quitting smoking. Now, they were slightly higher in the psychiatric group, but again, there was no significant difference between the treatment groups. So what they concluded was that there were no significant differences in neuropsychiatric events by treatment arm. And as a result of this study, which was under a very big microscope, I might add, very carefully designed, carefully monitored, but what the FDA said was as a result of our review of the large clinical trial, we are removing the boxed warning, FDA's most prominent warning for serious mental health side effects from the Chantix drug label. The language describing the serious mental health side effects seen in patients quitting smoking will also be removed from the boxed warning in the Zyban label. So we now no longer have a boxed warning. However, we still have a warning. And to be honest, this warning really should hold true for anybody who's quitting smoking, right, based on the results of this study. So let's go back to the table that Nirvana presented, but I want to add another line here. So we have all of the nicotine replacement therapies and the combination nicotine replacement therapies versus placebo, but now we're adding varenicline versus placebo. And this doesn't come from the EAGLE study. This actually comes from a different pooling, the Cochrane Database Systematic Reviews. They basically pull tons of research studies that are similar. Obviously, they're not identical, but they're similar enough that they can pull them together and look at the statistics in combination. And this is what they have revealed, is that the most effective, if you just look at the numbers, again, this is not a head-to-head trial, this is a meta-analysis, the most effective medication on its own as monotherapy is varenicline. Now, if you combine medications, the patch plus some short-acting nicotine replacement therapy, it's close. Now, adherence is a little more of a challenge with that than it is with varenicline, but bottom line is we should be recommending, unless there's a very good reason not to or a very strong patient preference for something else, we should be recommending varenicline or combination nicotine replacement therapy. That is what the evidence tells us today. Now, if you think about the cost, and Nirvana mentioned the pros and cons of some of the different approaches, some of them have generics, some of them don't. I believe varenicline is going off patent in 2020, so there will be a generic, I'm sure, available at some point, not too far down the line. But even if you're combining the patch and the gum, 4 to 5 pieces a day, you are still going to be lower than the cost of a pack of cigarettes. Okay, varenicline is higher, but again, it's the most effective. And so, if a person wants to save money, they might want to go with the combination nicotine replacement therapy. But if they just want to make sure they're able to quit and with the least amount of hassle in terms of dosing, then varenicline would be a good choice. Bupropion SR, as Nirvana mentioned, there's a good cost savings there if you use the generic. And the nasal spray and the inhaler are quite expensive. And again, also on prescription and doesn't get a lot of use, to be quite honest. It's really very specific cases for which you might recommend that. Okay, so coming back to the two-part problem, 2 parts to smoking, 2 parts to quitting. So we've covered the physiological, which we treat with medications for cessation, and you treat it for up to 12 weeks just to make sure that those patients are through the physical withdrawal. And while they're working through that, they are changing their behaviors, so they're not smoking. And so what we need to do, though, is to make sure that after we taper them off of the medications that they have strong coping strategies that will last them their lifetime, that they can resist tobacco use. Okay, and so we know that medications work, we know that behavior change programs work, but we get the very best outcomes when we combine those two together. And that's the evidence, and it's been that we've known that for 20 years, but unfortunately, this is not how most folks go about it. Most folks say, oh, I'm going to quit on my own. I can do it. I can just will myself through it. And it's true. Most people who quit have done so on their own without help. But they do it over and over and over again until they get it right. So if you want to maximize their chances of quitting now, you want to use this approach, combination of treating with medications as well as a behavior change program. Okay, so what are these non-pharmacologic methods that could be perceived as a behavior change? Well, cold turkey is less than 5% success, so we don't recommend it. And then some folks will taper down over time, and there's really nothing wrong with that if you really do taper down to 0. But what happens is they may smoke fewer cigarettes, but they're smoking more of each cigarette. They're holding it in their lungs longer. And there's an entire science devoted to how people smoke a cigarette. It's called smoking topography. And so, but again, if you taper to 0, 0 is 0. It's just how you get there. You know, your slope could be steeper, or you could actually do it the right way, and it would be less steep of a slope. We have formal cessation programs, self-help programs, individual counseling, group programs, telephone counseling with 1-800-QUIT-NOW. We'll talk more about that. And I've listed just a few different web-based counseling. There are a lot of them. There are apps as well. Tons of options. Have all of them been evaluated? Not really. But, to be honest, any type of help is generally useful, and patients will migrate toward what is best for them. I personally would never go to a group program, not my personality. But telephone counseling, yeah, I would do that. So, different things, different strokes for different folks, as they say. But these 3 listed here are very useful, have great information. QUITnet.com was developed by a group with some funding from the NIH, so I feel like it has, had a little more thorough review. But all of this has good information. Now, I want to kind of back up just a little bit and talk about the, different types of interventions from clinicians, because I know you all are in the home health area. So some of you, I know you're providing CE for nurses, so I know a lot of you might be nurses, but in other disciplines as well. And we know from the clinical practice guideline that when you get help from a clinician, your odds of quitting improves. So if you think about the referent group with getting no help from any clinician, if you're a non-physician clinician, that would be the pharmacists, the nurses, the respiratory therapists, et cetera, all grouped together, you get about a 70% increase in the ability to quit. If it's a physician, they have a bigger impact, but unfortunately, they don't have time to do this in practice, right? The appointment times are being squeezed even more down, not just 15 minutes now, most of them are going to 10 minutes. So if you get help from any clinician, you have a significant improvement in your ability to quit for long term. Now, what we also know, and this really speaks to interprofessional education, and I love this graph because in all the health professional schools now, we're all trying to do more team-based approach to care, and I think this is where home health comes in as well, because you are an extension of the office. And so the number of clinician types can make a difference. So if a patient gets help from one clinician, and these are different studies, 37 studies, so quite a lot, 1.8 is their odds ratio for quitting. 2 is 2.5. 3 or more is about the same. But you never know what type of clinician is going to resonate with a given patient. So if they hear the quit smoking message and I can help for multiple types, they are more likely to be able to quit. So do think about this in terms of interprofessional care when you're helping your patients with quitting. Now, I'm going to transition even a little more in talking about models of care. So we have the 5 A's, and this comes from the Clinical Practice Guideline, which is cited on this slide. You ask about tobacco use, you advise patients to quit, you assess their readiness for quitting, right? And if they're ready to quit, then you assist them with quitting and you arrange follow-up, okay? So that is comprehensive tobacco cessation counseling. What I'm showing you here is brief counseling, and this has been advocated for since, I want to say the early 2000s when the telephone quit lines were starting to proliferate over the U.S., and every state has one now. And so because physicians, nurses, et cetera, don't have time to implement comprehensive counseling in practice, we want them to plant the seed, just asking about tobacco use, advising them to quit, and then referring them to other resources if they're ready. And those resources can help with assisting them in arranging follow-up. Okay, and so this very brief Ask Advice Refer really can be implemented in less than a minute. And truly, you are planting the seed. Even if you just get the patient to start thinking about quitting, you've made an important progress. So here we put this into a pharmacy practice model. And the reason I bring this up is because I'm going to show you some information in a minute about where pharmacy is going with respect to tobacco. And I think if you're working in home health, you're in the community, and patients might need help, and that, you want a patient to get help with quitting smoking when they're ready to quit, and not a month, 2 months, or 3 months later when they can finally get into their primary care provider to get a prescription for, say, Chantix, okay? And so pharmacies have really moved along in the last, 20 years since we developed Rx for Change. But the model that we're using now is Ask, Advise, Refer. However, we throw in an extra piece where we help the patient select and we counsel on appropriate use of pharmacotherapy. Now, we also involve the technician in the process of asking and advising, but the counseling has to come from the pharmacist. And even if the patient doesn't have time or isn't ready to quit, the technician can still give the patient a tobacco quit line card and say, put this in your wallet. Every time you see it, let it remind you of the importance of quitting. And that's a very benign intervention. It doesn't take much time, but it can be very effective. Okay, and so this is the model that we're pushing for now because we know that it works, and we've actually shown in a randomized trial in Washington State and Connecticut, that just having pharmacists Ask, Advise, Refer significantly increases the number of calls to the quit line from patients who were referred by pharmacy. So let's walk through the Ask, Advise, Refer step. So first of all, and this is something that you can do when you're working with patients, really anybody can do this. You want to ask about tobacco use with a tone that is sensitive, it's non-judgmental. Here's some language here on this slide that you can use, or you can come up with your own. And I always tell our students, you'll come up with your own voice, your own way to ask the question. But you want the question to be all-inclusive of all forms of tobacco, but also nicotine, so particularly related to e-cigarettes and the vaping epidemic. So if they have tried to quit before, you want to ask them about what they've tried in the past and did they get help, right? Because remember, the two parts to smoking, the two parts to quitting. If they failed in the past, there's probably a good reason. They either, didn't get help, they didn't plan, they didn't use the medication. If they used the medication, they didn't use it right. So these are all things you can help them to examine, right? It's like if you fall off your bike, you think about what you did wrong and what you might do differently next time. The second step is to advise. The best way to quit is to combine smoking cessation medication with a support program. So you've given them some information about how it is best to go about quitting. And to be honest, most patients don't know this. Would it be helpful to discuss the medication options that might be appropriate for you? And then you can review their current tobacco use, what might be a good option for them, weigh the pros and cons that Nirvana just went through. And really, she wasn't trying to teach you everything about the meds. We didn't have time for that today, but really just kind of, as she says, how to navigate through them, and really not just for you, but to help the patient navigate through that. But at the end of the day, the patient has to want to quit. It's their decision. It's our job to help them, guide them if they do choose to quit. But what medicine they use or what programs they use, it's their own preference. But it would be helpful for them to know in advance, as it would for any of us, what a medicine's going to cost before we go get it filled or go buy it, right? So very useful information. The third step is refer to some type of behavior change program. And here I have some QUITLINE cards, 1-800-QUIT-NOW. And say, here are some suggestions. Which do you think would work best for you? You might even create a flyer of what is available in your area where you work. Maybe there is a group program. Maybe you've got some web-based programs that you like. Patients don't know. But if you convince them that getting help is going to make it better for them so they don't have to try this over again and again, then they'll be more likely to succeed. And I think they'll be more likely to try these methods as well. So what are the tobacco quit lines? Just very quickly. Anybody in the U.S. can pick up a phone and call 1-800-QUIT-NOW and get help with quitting. It's highly trained specialists. And I know this. I have actually sat next to the QUITLINE coaches out in Seattle that are with Optum. We did the research study with the pharmacies, and I listened in, and let me tell you, they were really good. So, but you should know, develop some confidence in what these are and what you're recommending. And depending on the state, you can get up to 4 to 6 personalized sessions. Sometimes for pregnant women, you can get even more. Some states, for example, Indiana in our state right now offers free nicotine replacement therapy, 2-week starter kit of either the gum or the patch. For free. And so they don't have that all the time, but they have promotions where they do that. And you can get up to 30% success for patients who complete the sessions, which is good. I know, I wish it was 70%, but, quitting smoking is hard. And so 30% is actually about as good as you can get with anything. So unfortunately, many healthcare providers and most patients really aren't familiar with tobacco quit lines. They might have heard of it, but they don't really know what it entails. So part of what we can do in any health setting is to advise patients on what these are and that they do work as well as anything else. So when they call the quit line, lots of different languages spoken. So, if you've got somebody who doesn't speak English, no problem. There's a brief questionnaire that's asked of everybody. That's kind of a North American quit line consortium developed this survey to collect data on who's using the quit line. Talk about smoking behavior, and then they can get individual counseling. They'll get literature mailed within 24 hours, and they can be referred to local programs. And we do know that the quit lines are effective, they have broad reach, and they are a recommended effective strategy in the clinical practice guideline. So recommend with confidence. Now, the other thing I wanted to mention was pharmacy, because this is, as I mentioned, is expanding. Back in 1999, we started doing a much better job of training pharmacy students for tobacco cessation, and this is the only discipline that has done this. In 2004, New Mexico became the first state to permit pharmacists to prescribe all of the smoking cessation medications. So, and since that time, not one negative report has been filed related to pharmacists prescribing these meds. And this went all the way through the Chantix with the black box warning, the Zyban black box warning, no negative reports. And pharmacists with patients coming in have quit rates that are estimated between 18% and 25%, which is good. As I mentioned, for patients who do all the quit line sessions, they have a 30% quit rate. So this is right in there. This is comparable to other interventions. And if you look at the statistics here, VARENICLINE was one of the most commonly prescribed. And this actually didn't include the years before VARENICLINE came on the market. So I would say now it's probably it probably is the most commonly prescribed by those pharmacists. And so what also is interesting is that 35% of the patients that were assisted were non-white, 21% Hispanic, and 53% had no health insurance. So these folks that are going to the pharmacy are the ones who aren't going to the doctors or the nurse practitioners or the PA. So really capturing that, marginalized group with respect to health care. So an important receptor site for patients who want to quit smoking. And then more recently, in 2017, the Center for Medicaid Services recommended that the states allow pharmacists to prescribe medications such as smoking cessation medications, naloxone, and vaccinations. And so we have 3 ways that we go about doing this. We have what's called a collaborative practice agreement. I'm sure you've heard of these. Basically, a clinician has a specific protocol or allows a specific pharmacist or a group of pharmacies to prescribe under their name. We also have independent prescribing for smoking cessation in Idaho. They don't have to be under any protocol. They just do it. And a lot of other states, I'll show you in a moment, have statewide protocols. And so if you're interested in learning more about what's going on with respect to this, I have a website here so you can look for your own state to see if this is coming. But as of today, and I highlight Indiana, that's where we are, the states that have protocols where pharmacists can prescribe are listed here. Now, the ones that include varenicline and bupropion SR are the more recent ones. Some of the other ones were older. California, for example, they're working on adding varenicline and bupropion SR now, but their protocol went into effect before the black box warning was removed from those medications. But since it has been removed and since there's been no reports from New Mexico and most of the states that are moving forward with this legislation, you can see the ones listed down here. I think there's 14 of them in process. These states are trying to get prescriptive authority for all medications, so patients have access to all of them on their street corner. All right. So why pharmacy? I mentioned that we've got them. The accessibility is very high. 95% of Americans live within 5 miles of a pharmacy. I think that's a statistic. Extended hours, weekends, holidays go far beyond the the typical primary care physician office hours. And we've enhanced access to uninsured, underinsured, rural areas. And as I mentioned, decisions to quit are often spontaneous. And you don't want someone to have to wait a couple months to get in to see a prescriber so that they can get the medications that they need and would like to begin today. So the medications are safe and effective. Patients need more timely access. Pharmacists have comparable efficacy as other interventions, and we have shown that the profession teams very well with the tobacco quit lines by using the Ask, Advise, Refer method. So I think that this is a way of a future for pharmacy. We've been working with the CDC. We work with the Surgeon General's office and all of their commissioned officers and pharmacists to really advance the role of pharmacy, because something has to be done differently. What we're doing now just isn't enough. Patients need greater access. We know the meds work. We know clinician counseling works. So let's expand it and think a little differently and outside of the box. So I'd like to conclude, because we'd like to have a few minutes for questions, but just to summarize what Nirvana has covered as well as what I've covered, quitting smoking has immediate as well as long-term benefits. It's never too late to quit, but it's also never too soon, right? Too late, there's always a benefit. It doesn't matter. No matter how old you are, you can still get a benefit. The medications and behavioral counseling is the most effective approach. We know this from hundreds of studies. The most effective is varenicline, Chantix, or combination NRT. And behavioral counseling has very different options for folks to choose from. Pharmacy-based interventions are also effective for cessation, and really truly for any clinician. When you don't have time or you don't have the expertise to do comprehensive counseling, simply ask, advise, and refer to the quit line, and know that you're handing your patient off to good hands. And legislative advances are providing pharmacists with new prescriptive authorities that I think is really going to move the needle with respect to tobacco cessation. So finally, I love this statement, and I think it really summarizes what my personal feelings about tobacco cessation is it is our responsibility as health professionals, because it is completely inconsistent to provide health care of any type and at the same time remain silent and completely inactive about a major health risk. If I'm dispensing a medication for a heart drug or a pulmonary drug, or really pretty much any drug, I should be asking about tobacco use, and I should be encouraging my patients to quit. It makes a difference, and sometimes it just doesn't take that much time to plant the seed to help the patient start thinking about it, but without making them feel resistant or judged. And again, it's all about the tone of voice and how you ask the question, how you offer help, how you try to develop autonomy with your patient, and let them know that you're there to help, not to judge or criticize, and that it is their decision. And think about tobacco cessation as an important component of therapy. Nicotine dependence is a chronic brain disease. It changes the brain, and it takes time for it to get back to normal. So additional training that Nirvana mentioned at the beginning, if you are interested in getting more training related to tobacco cessation, more in-depth knowledge of the medications, et cetera, we have CE programs that we offer at no cost through the Purdue College of Pharmacy. They're shown here. This is the website. We have a 2.5-hour program on behavioral counseling and pharmacotherapy. We have some programs that we've developed for the U.S. Public Health Service. Like I said, we do a lot of work with them. A respiratory therapy program, and then we also have a Train the Trainer program. It's 6 hours, and it walks you through basically the whole RX for Change program and teaches you how to teach it, But even if you don't plan to teach it, if you really want more in-depth knowledge from the experts on these topics, I encourage you to do that. And again, it's all at no cost. We provide RX for Change and all of our programming as a service to the public health community. Okay, so this is my contact information and Nirvana's as well. And at this point, we would like to take questions.
Thank you very much for that presentation. I will echo some of the comments that have been coming in, which is this was an excellent presentation, very concise, yet very informative. So I want to remind everyone, if you have questions for our presenters today, to go ahead and put them in the Q&A box on the right-hand side of your screen. If you are watching this as an archived recording and you have questions for our presenters, we want to encourage you to send them in to hhqi@qualityinsights.org. With that in mind, we do have a couple questions that have come in, and I'll go ahead and ask you, I'm just going to read these as they came through. First, can you speak to vaping and e-cigarettes?
Absolutely. I'm not sure what specifically. Currently, we don't. It's not an FDA-approved medication for smoking cessation. However, there was a study that was published I think January 31st in the New England Journal of Medicine that provided evidence that it can be effective for individuals who want to quit smoking, but it did not actually transition them to no nicotine. So it depends on what the patient's goal is. Do they want to quit smoking tobacco or do they want to quit nicotine? So for those who want to quit smoking tobacco, there are people who believe that e-cigarettes are effective in transitioning people off of tobacco onto e-cigarettes now. There's very little evidence that it will get them off completely. So again, it depends on what the goal is. What we want to make sure we avoid is dual use, meaning you're vaping and smoking tobacco, because that actually can be worse than either one alone. And so the data are still coming in, and I'm sure they will be. We don't know the long-term effects of vaping. I would be hesitant to recommend it to anybody as a clinician, just because it hasn't been proven to be safe or effective for quitting nicotine. And my goal for patients is to be, addiction-free. And so I think it, again, just depends on what the patient's goal is. And just be very careful that if you do make a recommendation, and believe me, there are people who are doing it. I'm not one of those people yet, but I try to keep an open mind, that you want to make sure that you document that you have given them all of the risks that you're aware of. So should something bad happen, you don't want to be the person that's liable for that patient's decision not to quit nicotine, rather to quit tobacco. Does that answer the question, or would you like more?
I think that it does, but if the person who asked this question has any additional follow-ups, please send them in and we'll be glad to. The next question we have that has come in is, this has been a great presentation. Thank you. What have you found to be the best way to address the public concern with Chantix to increase adherence?
Okay, I'll take that one too because I covered it. So I actually had a video that I wanted to show of a patient saying, Chantix, isn't that the drug with all the horrible side effects? And what I would do is I would reflect and say, sounds like you've heard a lot of, negative press about this medication. Could I share with you some more recent information about, from a study that was conducted that really deeply examined the safety of the medication? If they're willing to hear that, I would just walk through exactly what I just told them, what I just told you all, which is, study, and it showed pretty clearly that Chantix is the most effective of the medications, and it doesn't have any more safety concerns than any of the other medications, and that those side effects that everybody was talking about very likely was a side effect of quitting smoking based on how that study rolled out. So that's how I would address it. I don't know, Nirvana, if you want to add anything else, how you would in clinical practice.
I would do the same thing. I would share clinical studies. As a pharmacist, I found that patients trust what scientific studies found. So when I tell patients that, science has told us, so-and-so, there's been publications talking about the safety concerns of chain links, and we have found none. Just the reassurance would help patients. And I found them to trust pharmacists and trust their opinions and trust what we tell them about the scientific evidence.
Yeah, and the other thing is I would tell them that the FDA took the black box off, and that has only happened 4 times in history. And those other removals of the black box were for strange little things that hardly affects anybody. This was really the only major black box removal that could affect a lot of people. And they don't do that lightly, you know. So it's very cautious that they do things like that.
And that's very interesting. I didn't realize this was the only 4th time in history, so that's really good to know. Thank you for that. And thank you for the person who asked that question, because that's going to help me in my practice too. Another question that has come in. Are you aware of any prescription drug assistance programs for clients interested in Chantix but without health coverage? Where would I direct interested parties?
That's a good question. So a lot of states through Medicaid will cover the medications, and more of health insurances. I'm not aware of any drug assistance programs. Are you, Nirvana?
No, just because it was covered by some insurances when I was in practice.
But no, none of like safety net type. No, I'm not aware of any, unfortunately.
No, but that's good to know, and thank you for sharing that. That saves us from, as clinicians, going out and spending a lot of time looking for something that doesn't exist at this time. The next question is, and I won't preface the way this person asked it because this is, I think, is a very good question, and it's something that it's basic that we all wish we knew, but I think it's coming up more and more. What is worse, the nicotine or the chemicals in the cigarette?
Oh, hands down, the chemicals in the cigarette. Not even close. Well, even more specifically, it's a combustion product of tobacco that is the most harmful, the polycyclic aromatic hydrocarbons that causes most of the problems. So not to say that smokeless forms of tobacco aren't harmful, they are, but the combustion actually causes a lot of problems too. So to me, there's no comparison. I would rather see someone on a lifetime, supply of nicotine gum than smoking. So not to say that nicotine is not harmful at all. It does have some harms, but the comparison is not. It's not even close.
That's good to know. Thank you.
Sure.
We'll come back to additional questions. If you have any more, go ahead and send them in. I will just take a moment to go through a few additional resources in addition to what our presenters talked about today. These are available on the HHQI website. Some of these were referenced in the presentation. Looking at the Cardiovascular Part 2, Cardiovascular Health Part 2 Best Practice Intervention Package. It does cover smoking cessation. It also is available in Spanish, as you can see. The blood pressure control and smoking cessation, the focused fundamental BPIP is also available with additional resources to assist you in caring for your patients and trying to support them as they go through tobacco cessation. Additional videos, some of these are for the patient and some are for the clinicians, as you can see listed here. These are short 4 to 6 minute professionally created videos that can be downloaded, either streamed live through MP or downloaded on MP4 players, so that you can show them in the homes to your clinicians, or you can share with the other community providers that are also in the same boat as you, as trying to help all of our patients reduce their smoking and tobacco use. For those of you that are interested in continuing education hours, your CEs are available, and you can download a certificate by following the step-by-step flyer. Make sure that when you log into the university, if you are not sure of your username or have any difficulties with it, contact us at the email at the bottom at hhqi@qualityinsights.org, and we'll be happy to get that for you. We would like to discourage the creating of a second account. That will just lead to future confusion for you, and we don't want that. So if you have any difficulties with this or any questions, make sure to contact us, and we'll be glad to help you with that. One final question came in, and I think we have time for it, if that's okay with you. It is just really asking about, many of our patients are first admitted after a tobacco-free hospitalization. but as soon as they are home, they seem to fall back in their old habits of smoking. In addition to pharmacological methods, what is the best way for us to help them continue their tobacco cessation once home? Should we start with the ask, advise, refer, or is there something else we should do in this situation?
I think in the hospital there's more time for the 5 A's. Go ahead, Karen. Sorry.
No, go ahead, Nirvana. All yours.
I was just saying, because this is a hospital setting, there's more time to interact with the patient, and I think this is a good opportunity to apply the 5 A's rather than the ask, advise, refer, just to make sure they are on the right track and make sure they don't slip back to smoking. Karen, you wanted to add something?
I do. I think that part of it is about discharge counseling and making sure that there is a handoff that is appropriate. So, for example, if you do the 5 A's or as much as you can while the patient's in the hospital setting, make sure that discharge planning includes an active referral to the tobacco quit line. And by that I mean it's a faxed referral to the quit line for the quit line to call the patient. Of course, the patient has to be on board with this. They really need to buy into this. You also would want to make sure that they talk about coping strategies for what their triggers are in their home. If there are other smokers in the home, you might want to have a conversation with them if they're amenable to that. And you should also contact their primary care provider to make sure that they're aware that the patient is quitting and see if there's any type of support that they can provide. You know, the more support these patients get, the better. And you're right, it's a window of opportunity, but that window can shut very quickly if the right support is not available in that environment, because the hospital environment is completely different than the home environment and the regular life environment where smoking is very much ingrained in everything that they do. So they need to be prepared. You need to make sure that you assess that they understand the importance of quitting, talk with them about their readiness to quit and their confidence. And if their confidence isn't high, then you want to work with them to improve their confidence. So the three things I like to address are perceived importance, readiness, and confidence. And those are some of the most important things you can measure with any patient to kind of figure out where they are and what type of help that they need. But more help is better.
I think that was a great way to conclude our session today. I will just share 2 more comments that came in. In regards to Chantix, there is a comment from a participant that is saying that coupons are available to patients at lower cost. And in regards to will this presentation be available for sharing, yes, it will be. It will be in the HHQI University, and it will be there shortly. We would like to thank everybody for joining us today, and especially our guest experts. Thank you for your time. Thank you for sharing your expertise and being so generous with your content. And with that, we will say thank you, everyone, and have a great day.